Hi, my name is Mitch Rogers and I'm the System Administrator over Cardiology. And I'm sitting here with Dr. Agarwal, who is a Springfield Clinic cardiologist. And today we're going to have a short conversation about TAVR, which is one of the new innovative procedures that we're doing here at Memorial Medical Center. So as we go into this conversation, we're going to touch on three different things. The technology itself, the innovation around it, how we're doing here at Memorial, and what are some of the issues that we see in getting patients in. So Dr. Agarwal, can you give us a little bit of background on TAVR and where it started?
Certainly, Mitch. I think TAVR is an innovative technology introduced in France in 2002, and it has been 17 years of discovering and perfecting the technique. In 2012, FDA approved it for the United States for people who were inoperable in terms of surgeons saying that they are very high risk for surgery. And it went to then high risk. And 2016, we went to patients who are intermediate who can either go for surgery or who can go for TAVR. And just recently, it's very exciting that we have data about low-risk patients who are young and who are otherwise healthy. The data shows that TAVR works equally well as compared to surgical aortic valve replacement.
So when we talk about TAVR, it's an acronym. Can you tell the audience what the acronym stands for?
It's a transcatheter aortic valve replacement as compared to open heart surgery where the sternal needs to be split and patients need to go on pump to get a valve replaced. On a beating heart, we are able to put in some large tubes in the legs commonly, in the femoral artery. We go up with the catheter. We place a valve in the center of the diseased valve, and we are able to blow up a new valve, which functions amazingly good in place of a diseased valve.
So we've been able to give these patients their lives back to them with a minimally invasive procedure that results in good outcomes or great outcomes, improvement in the patient's quality of life. We're able to do it in a way that we can get them in and out in a fairly reasonable time and have great outcomes. I would say that that's a great combination. I see we have a model here of the heart, a very big heart, and we have a couple of things here. Can you walk us through what we have here?
Yeah, I think this is the main pumping chamber of the heart called the left ventricle. It is the workhorse for the heart. Whenever the blood is squeezing to the brain, to kidneys, to the whole body, it has to come out through an exit valve, which is called aortic valve, and it has to go into this big red pipe here called aorta, going through this valve. Usually, the size of the aortic valve is large, about 3 to 4 centimeters square in diameter. In patients with severe aortic stenosis, it gets to 1/4 of the usual size, and that is why they are not able to perfuse their brain and their organs very well, despite the heart trying very hard to work and overcome that obstruction.
Resulting in shortness of breath, fatigue, just overall a decrease in your daily functions. But it happens kind of slowly over time, so you really don't notice it at the onset, but it gradually sneaks up on you, and the next thing you know, you can't go out and do what was normally normal for you. Now it's a big task, correct?
That is correct. I think, and because it is so insidious, a lot of times our elderly, they will decline in their activity, and if their providers ask them, are they having any symptoms? They're like, no. Because most of the people ascribe it to age. And I tell them that you didn't get aged within 2 years or 3 years. And that is why they don't complain. They're like, we are fine. But once you give them a replacement with a new valve, their quality of life improves tremendously because they are able to do, and they get younger by almost 5 years. I have had patients who said, oh, I feel like I have got a new brain to think now.
So you came from Mount Sinai, New York, very large city, metropolitan area. How would you say Memorial is doing compared to a program such as that?
I'm very happily surprised that at Mount Sinai, we probably did over 200 in year 2017 TAVRs. Memorial, there is always this debate about whether we should only have few centers in the country doing it. But the outcomes at Memorial and the team approach at Memorial, where the surgeons, the vascular surgeons, all our techs and everybody else is very well apprised of what is going on. And we are able to provide similar or equal quality of care to our patients as in any big, large institution. To give you an example, like in our last 70 TAVRs, which I have seen here, there has been 0 mortality.
Okay. Well, those are pretty good outcomes.
Those are amazingly good outcomes for a procedure where nationally there is almost 1% mortality risk. And these are very high-risk patients. A lot of these patients, of the 25 I have been directly involved with, 12 have been over 90 years old. So over 90-year-old going through a big surgery like this, getting discharged most of the times the next day, participating in rehab and coming back to us, it's an amazing feat of technology of what we are able to achieve today.
Okay. Well, with that, I'm going to wrap it up, but this would not be possible without our great partnership with Springfield Clinic and SIU. Hopefully I'll be bringing you more videos to give you a lot more information around some of the cutting technology that we have here in Springfield, Illinois. I'm going to say goodbye. Thank you for your attention, and have a great day.